I'm Joe Helko, Director of Community Relations for Northwestern Counseling and Support Services, and welcome to another episode of NCSS Here for You. Since 1958, Northwestern Counseling and Support Services has been providing access to high-quality services which promote healthy living and emotional well-being to the residents of Franklin and Grand Isle counties. Over the years, as the needs of the community have changed, so too have the programs and services that we make available to assist children, adolescents, adults, families, and seniors. We take our role in the community seriously and strive to provide a continuum of the highest quality services to meet the needs of individuals who at any point seek assistance. This month's episode is titled Integrative Psychiatry for Mood and Anxiety Disorders, Part 2. Shortly, we'll be going remotely to the second part of a Grand Rounds presentation by NCSS Medical Director, Dr. David Mooney. There are some individuals that don't respond well to traditional therapy for depression. However, many times there are nutritional reasons why therapy doesn't work for some people when treating for depression. In today's episode, Dr. David Mooney discusses micronutrients, vitamin D, zinc, and magnesium in the integrative therapy treatment of depression. So now, let's go to NCSS as Dr. Mooney continues his Grand Rounds presentation.
Vitamin D deficiency is a potential predictor of depression. I would say that, again, I see mostly kids, but I would say 80 to 90% of them have low vitamin D levels. We live in Vermont, we don't get much sunshine. And low vitamin D is any vitamin D you get, if you go to your PCP tomorrow and you get a vitamin D level, they're going to say it's okay because the level in the range is usually like 20 to 50. It should be above that. It should be 50 and up, and there's research to support that. So that's just important to know that the cutoff is more likely to be 50 than 20. But even with the normal range, so many of my patients are low in vitamin D. Yeah. Okay. There's another study, just throw up there for vitamin D and depression. Prenatal did that. Okay. Vitamin D and suicide risk, that's big. There have been studies about omega-3 levels in soldiers. And suicide rates, and previous studies with omega-3s, low levels of omega-3s, indicating those that were more apt to complete suicide. Same thing with vitamin D in soldiers, active military members. Kind of scary. Genetics, well, this is just to remind us that, and I don't think people think about this, there is some people genetically absorb vitamin D better, absorb sunlight better, and are able to manufacture vitamin D better than others. So there is a genetic component there too. Prevention, little kids, we know with little kids, 10-year-old little kid with a good, healthy vitamin D level is less apt to be depressed 4 years later. It's also preventative. Okay. We know there's all kinds of inflammation, and inflammation can also come from people that are deficient in vitamin D, but inflammation across the board is never a good thing. You think of so many things can cause inflammation: diabetes, cancer, MS. When people are getting medications, they're inflamed. Even if you have simple things like leaky gut, not like that's simple, but that sets up an inflammation. We got all kinds of inflammation going on, and when you're deficient in vitamin D at the same time, the results aren't good. I think pharmaceutical companies are working on this because they're figuring, if we can get an since there's all this stuff about inflammation going on, if we can get an anti-inflammatory that we can sell as something that would help with mental health, since that's part of the whole inflammatory process, maybe that might be a good thing. Yeah, but they're all related. I mean, everybody, well, not everybody, but you think of people with cardiac disease are depressed. People who are depressed often have cardiac disease. It's not like there's just a direct link to both of those things. It's because they're both inflammatory disorders. People who have diabetes are often depressed. They're all within that big inflammation pool. So if you're deficient in vitamin D, that's pro-inflammatory. This is just really confusing. Bottom line is you get an inflammation and you get these cytokines which respond to inflammation at any place in the body, and that enzyme there is increased, and all that matters is, the only thing about that is you see that all these neurotransmitters are lowered. You need all those for your mental health. Bad things, this is quinolinic acid, which is a marker of inflammation in the brain, not good. Glutamate, that's an increase in glutamate, that's not good either. But the take-home message is, you get inflammation, you get these cytokines, they make that enzyme, and these, then you get deficiencies in tryptophan, serotonin, and all those other things. Back to Dr. Greenblatt's zebra approach. Under the Z is zinc. So zinc is really important. Zinc is involved in like about 100 different enzymatic reactions in your body. And in your gut is an enzyme called carbonic anhydrase, and that is the enzyme that you need to make hydrochloric acid. You need hydrochloric acid to break down amino acids and proteins, and all digestive enzymes. All digestive enzymes are zinc dependent. So this is kind of important too. When we think about treating anorexics, when you think about an anorexic eating a meal, they sit down and I'm full, I can't eat, And back in the day, we would say, well, that's their illness. They never eat, and that's partially true, whether it's purposeful. I think back years ago we used to say, well, maybe that's more purposeful and that's part of their whole restricting thing. But as we've looked at this further, and if you look at the zinc levels in anorexics, you'll find a lot of them are low. So if you have low zinc, then you aren't activating all these enzymes that you need, the lipases, the proteases, all those things. You aren't activating that carbonic anhydrase, which you need for hydrochloric acid to break down all this other stuff. So the point is, these anorexics that we've thought all along is this is a behavioral component of their illness. There's actually a physiological cause for it, and oftentimes it's a zinc deficiency. So this just reminds us that zinc is involved in many, many different enzymes. And what we just said, if you don't have enough zinc, you can't, carbonic anhydrase isn't activated. When I look at this, so this is zinc deficiency. When I look at this, I think, well, that's anorexia. Every one of those boxes would apply, in my opinion, to anorexia. So there you have it. I mean, those are all symptoms of that illness. Malnourished. Zinc supplements. Obviously, if you're deficient in zinc, you should take it. But we really need it for digestion and just for our basic nutrition. Interesting thing here, women showing a reduction in hostility and low Hamilton depression scores and Beck depression inventory scores with zinc supplementation. Here's a study, a 12-week study, zinc supplementation supplementing antidepressants. Increased depression scores, treatment-resistant patients. Same thing here, low zinc, and you get depression. Zinc and copper are related. If you have low zinc, you often have high copper. If you have low copper, you often have high zinc. And it's a balancing act. And you have to be careful with that balance. I get these in kids a lot because they can be related. Well, zinc is important for everybody, but sometimes with high copper levels, we see that in kids who are just really agitated and aggressive and stuff. And there's a certain ratio that I follow, and if it's below that, the ratio is 1.2. If the copper over zinc ratio is above that, I know they're probably deficient in zinc and they've got more copper than they need. Low copper can be a cause of, or a source, or contribute to depression. Zinc can get deficient. You find deficiencies of zinc in athletes who sweat a lot, hot yoga. Yeah, sweating a lot, you lose zinc. Yeah. Copper, the other part of the balance is, if you make the New York Times, you must be important. So they have this little thing that they did in the New York Times. They used to have this, I don't know if they still do, but once a week they would have a think like a doctor thing, and they would give you all these clinical signs. They would give you like a case scenario and you had to figure it out. But this was, because it was in the New York Times, I guess it made this slide. But anyways, this is about, this was a case of high copper in celiac disease and symptoms of fatigue and hair loss. Yeah, excess copper. You don't see that in adults too much. You're more apt to see it in kids. Where do we get copper? From water pipes. Yeah. More often, excess copper more often in kids. This is my favorite one here, magnesium. Personally, I use this a lot too. Use it a lot in ADHD for anxiety, irritability, sleep, constipation, those 4 things. All these kids have that. And it's easy to use. As you can see, it causes all these incredibly positive benefits. Changes in mood, healthy eating. Yeah. It's just a good thing. It's a safe thing. Our diets, our food doesn't have the magnesium, or probably our soil doesn't have the magnesium in it that it used to. So that's something that I probably supplement more kids than not with magnesium. And when they get diarrhea, you've given them too much. This is magnesium, so you got the HPA axis here, which is the whole stress axis here. And cortisol, the end result of the HPA axis here through the adrenals, is our stress hormone. How many patients have you heard say, oh, my anxiety, we talk about anxiety, but then when you talk about panic, oh my God, when I get up in the morning, it's through the roof. I wake up feeling panicky. Or people wake up in the middle of the night. People wake up in the middle of the night saying, oh my God, I woke up, I couldn't breathe, I was having a panic attack out of nowhere. Well, usually if they say, I woke up in the middle of the night and my heart was pounding and I couldn't breathe, I don't need to hear anymore, you had a panic attack. That's cortisol. Cortisol doesn't usually release that early, but it certainly does. It's an early morning hormone that increases, because the purpose of cortisol is to get you going, get out of bed, get going, you know. It's a stress hormone. But the point is here that, so magnesium, Jesus, I'll figure this out eventually. Magnesium works the opposite way. So magnesium helps suppress that response. So you've got a patient, an adult, a child that's complaining of being kind of energized, activated, stressed out, anxious, panicky in the morning. Good patient to give some magnesium to. Low magnesium intake and depression. Okay. So does help with mood. This is a randomized controlled trial. Thing about magnesium that's interesting too is there's all this stuff in the news about ketamine. You probably heard about that. Using ketamine in emergency rooms they hook you up to an IV, give you ketamine. All of a sudden you aren't depressed in 30 minutes, which is fantastic. I'm not sure exactly how that works, but anyways, also using ketamine for postpartum depression, using it intranasally. Problem with ketamine is because you have to monitor these people. They're going to have a cardiac collapse, you know. So I've got my choice of magnesium or ketamine. I think I'll probably take the magnesium, but the reason I also say that too is because it's interesting because they both work on they are both NMDA receptor antagonists, so they both hit on the same site. But I mean, obviously, an infusion of ketamine is going to have more of an impact than 200 milligrams PO of magnesium. But I think it's interesting that they hit on the same receptor. I don't know about this. This is interesting. I'd like to think that magnesium could be as effective for your anxiety or your panic as a benzo. I tend to doubt it. I'm not saying that benzos are good, but boy, I think that's a leap. But the point is, it's good for anxiety. As far as better than benzos, not quite sure about that. But anyways, there's the article if you want to check it out later.
What's that journal name?
It's a good question. It's a foreign one for starters. Looks like.
It's not short for magnesium?
Oh, yeah, MAG, yeah. Magnesium Resources or something, I don't know. Do you want to check it out later? You want to get that? Yeah, okay. Fairly recent, 2016. A lot of the research in integrative medicine has been done across the water, but if you also think of and a lot of our here's the whole NMDA receptor antagonist thing. Just saying that magnesium supports GABA function just like ketamine would. I think this was put in here because I think the story with this slide is that this was a very successful author. Again, New York Times, you make the New York Times, it must be right. Very successful author who was bipolar. She was on lithium, pharmaceutical lithium for years, did remarkably well, but then developed renal disease and had to stop it, and her clinical course wasn't so good after that. But it's interesting that it's just interesting. So lithium. So there's lithium that we use for our bipolar patients all the time, use it every day, and typically use doses of whatever, I suppose as low as 600, 900 up to 1800, sometimes even above that, but that's pharmaceutical lithium, and I think we all know what pharmaceutical lithium is, and we all know the population that's used in. But there's also nutritional lithium, which is in our water, and 7-Up. The drink 7-Up is the atomic weight of lithium is 7, which is for lithium, which was in 7-Up back in the day, and it was in 7-Up to help people with their moods. This is also lithium, nutritional lithium orotate was used even before that, like the early 1900s for hangovers. So it's been around for a while. I'm talking about, there's a difference here. I'm talking about nutritional lithium, not the lithium we give our patients. And nutritional lithium orotate is like 1 to 5 milligrams. You rarely need that much. And I've got some kids that I have on lithium orotate. Typically, it's the clinical scenario would be a family with bipolar disorder, very volatile, yelling, screaming, substance abuse, child's off the wall, lots of energy, misdirected, but not like bipolar. These are the kids that seem to respond pretty well to lithium orotate, and you really have to adjust the dose. You don't have to get levels, because what's 5 milligrams of lithium going to, you'll hardly be able to measure it. You don't have to worry about the thyroid. You don't have to worry about the kidneys, because you're giving such small doses. But it's really interesting. Lithium in general is probably one of the biggest, whether it's pharmaceutical or supplement, one of the biggest interventions for people with suicide, or it's a suicide ideation. So this is interesting. This is what I'm talking about, nutritional lithium, lithium orotate, and like I said, it's in the drinking water. So three places, Texas, Japan, and Australia, they checked out the lithium levels in their tap water. And lo and behold, overall suicide rate and suicide mortality were inversely associated with lithium. Those with the highest lithium in their tap water it had a protective effect, and vice versa. This is just a chart on lithium levels. If you're using lithium orotate or nutritional lithium, you're right in here. And then as we treat bipolar disorder, other mood disorders with lithium, here's where we go. Upper toxic, as you know, these are kind of the dose ranges. Yeah. These are the scenarios that are the types of patients that seem to benefit from lithium orotate. When you get that type of history that isn't bipolar, although you can use lithium orotate in bipolar patients too. So lithium, basically, whether it's nutritional or pharmaceutical, basically reduces these, which helps settle things, or this is what helps settle things, has a more calming effect. And here we're reducing neurotransmitters that are more excitatory. I haven't seen any of this literature, but there is apparently some literature about nutritional lithium in autism. I know there is some. I've read research on lithium orotate in Alzheimer's, and sometimes when you go to these conferences, you hear the most helpful things in the hallway, and we're all getting older. Our parents are all getting older, and it was very impressive to me, the number of people, when we're just kind of chatting, we were talking about nutritional lithium, the number of people that said they were giving it to their parents or their grandparents who had early cognitive decline, and how much they were benefiting from it. So I think, Jesus, I need some of that. Yeah. Yeah. But that's really interesting, I think. And I'll bet you start to hear more of that being used for not advanced Alzheimer's, but early cognitive decline. This is how you can check when you're using these low-dose nutritional lithium interventions. You can check for lithium with a hair analysis. And this happens to be a patient whose lithium is quite low, but I thought we don't do hair analysis here. I'd like to, but I don't know. I got to find somebody that does it. But for example, let's just say it was a child, and we did a hair analysis, and his lithium level was that low. I could say, aha, this is a child that might benefit from lithium orotate. Yes, okay. Lithium in clinical practice, clinical symptoms, I think we know them: irritability, depression, impulse control, mood swings, addiction, suicidal ideation. This is the mineral hair analysis I'm talking about. So let's just say we pulled your hair out and sent it somewhere, and it came back undetectable. And that's combined with this family history and these clinical symptoms. that would be a good scenario for starting some. Brain-derived neurotrophic factor is a good thing. It helps with develop dendrites and neurons in our brain. It's a very good thing. And nowadays, anything that that supports or helps brain-derived neurotrophic factor is good. You want that. Lithium does that. Exercise is probably the biggest. Exercise is probably the biggest thing for helping produce brain-derived neurotrophic factor. There it is there. These are all the things that work to produce it. This is interesting here, caloric restriction. You know these intermittent fasting? I think that part of that might be that you're developing brain-derived neurotrophic factor. Don't know. But all these other things, all of which we've talked about except for probiotics, help with the production of that. Okay, getting towards the end here. Won't have time for many questions, but let me just say, I personally don't think of this integrative medicine as alternative medicine. I know there are some colleagues that would use that word. I think it is complementary. I don't consider getting a B12 level, or which everybody should get anyways, or even doing some of the newer genetic testing. I don't consider that as alternative medicine. I consider that as what we should be doing. So I kind of have a hard time with that, alternative medicine. In fact, a couple years ago, UC Irvine received a $200 million grant to study integrative medicine. When that happened, some of our colleagues said, we don't want to support that. We aren't going to support this alternative medicine. Some of our Ivy League colleagues, to be a little bit more specific, said that's not worth support. We don't want to put money into that. We don't want to support this alternative medicine. So there's still a big wave against integrative medicine. Integrative medicine is, the point is, I don't consider what we've talked about today alternative. I consider it stuff we have to do. Like I said at the beginning, you have to find out why someone's depressed, not just that they're depressed, here's your pill. Why are they depressed? We all know there's psychosocial stressors and all these other things that contribute, and family history and all that stuff, but I think we need to take it one step further. What if you went to your primary care doctor and he said, "Oh, I think you got diabetes"? Yeah. Well, why? You'd like to hope that they did a metabolic workup and checked your glucose and all these other things. But so to me, there's no difference. And lastly, this is just a study on patient, double-blind, placebo-controlled trial. So there we go, doing everything right. On supplements, just multiple vitamins and a low dose of fish oil, omega-3s, and these are the numbers here. They followed them. They treated them for about 4 months. They followed them, and they had fewer offenses. These are prisoners. It's easy to do studies on prisoners because you control everything. You can control what they eat. You control what they do. So they're actually a pretty good population to study. And a 35% reduction in offenses. So this is the last one. Mental illness is seen as a reflection of multiple errors in physiology. If we find the causes, we may find the cures. So that's pretty much what we've been talking about. What are the causes, the whys, and prevention is possible. So, got like 2 minutes. If anybody has any questions. I hope that was helpful and informative. Yeah?
Do you know how primary care looks at micronutrients and things like this? Like, other than, measuring lead for children and talking about folate for women who are pregnant, I don't really hear about this.
Yeah, you don't. But on the other hand, I'm starting to see, like, some of the pediatricians that I'm working with, I think it's getting out there. Like, I'm seeing Yeah, I think, Rebecca, you probably know, I'm starting to see some of the things we're doing here that they're doing.
We have a couple of peds providers who recommend supplements and will now prescribe. We have probably 50% of our pediatricians. That's the route. If someone is coming in with concerns of ADHD or behavioral problems, they start with typically the omega, the vitamin D, and the magnesium are the three.
Do they do any testing first that you know of? I just wondered, do they check any levels or just prescribe?
I'm not sure.
I tend to, if I can. Obviously, there's some kids that I don't want to put through, putting a needle in their arm, But there's some that do, and if there's any chance, I usually do. But things like B6, you don't test for. But going back to the copper and the zinc, that's helpful. What I don't understand, well, I'm not seeing much testing going on out there, and I think that's probably driven by our healthcare system. But I haven't had any trouble so far ordering labs fairly frequently on kids. So to answer your question, yeah, I think they're starting to do some more of this for the same reason as in psychiatry. Okay, enough already. We gotta get underneath this and treat what's driving this. Yeah. Okay. No questions? Thank you. Yes.
Would it be better to take each individual nutrient like in and of itself, or does a multivitamin given to somebody have the same effect?
Well, of course, the multivitamin will help, but usually it's better to use supplements individually because then you can tailor the dose better. And oftentimes, there's good multiples out there, but oftentimes you need more if you're using them individually than you do in your multiple vitamin. Yeah. Things like vitamin D. I don't think there's a multiple vitamin out there that has enough vitamin D in it. Yeah. Thank you.
I want to thank my guest, Dr. David Mooney, for sharing his insights on the benefits of integrative psychiatry for mood and anxiety disorders. As we heard today, vitamin D, zinc, and magnesium can make a difference in the treatment of depression. I also want to thank you, the viewer, for spending time with us again this month. You can learn more about NCSS programs and services by visiting ncssinc.org. I'm Joe Halco, and I'll be back next month with another episode of NCSS Here for You.